This episode of Swallow the Gap is sponsored by the Milton J. Dance Endowment, a sponsor dedicated to the support of head and neck cancer patients and swallowing disorders in all populations.
My name is Laurie Sterling, and this is a special edition of Swallow the Gap, ASHA 2024.
That was really good. I like it. So in case you missed it, that was Laurie Sterling, and this is a special edition of Swallow the Gap at ASHA in 2024. Laurie Sterling, who are you?
I am a speech pathologist at Houston Methodist Hospital in Houston, Texas. I'm like, why am I saying? Because it's pretty obvious I am in Houston. I have been an acute care speech pathologist for over 30 years now. I did a fellowship in Baltimore at the same place.
Yeah.
One of our other guests here, Barbara Messing, did hers. It was like a residency, and way back before CF residencies were popular.
Before
Before they were known. Yeah, it was a clinical fellowship, but it was only for a
the
year.
original
You still
hipster.
call it
Yeah,
fellowship.
but it was only for a year, so it was kind of like a residency, and then
Yes.
you moved on.
That's right.
But I have been very involved with ASHA for a number of years, beginning with SIG 13, and
It's still a division.
when it was a division, yeah, way back when, became like the director, I don't know what it was, of education, and became involved with convention and co-chaired convention in 2019. And I am going to co-chair convention 2025, our
Look at
centennial.
that.
Our centennial,
Oh, man.
yeah, with four other wonderful clinicians, audiology and speech pathology. But
They're having 4 this year?
we're having a total of 5. It's a co-chair council, just something special for the centennial. Yeah,
That's fantastic.
And it's
So-
going to be held in Washington, D.C. So
yeah.
get it on your calendar.
Is it going to be the week before Thanksgiving?
It's going to be the usual time it is.
Okay,
yeah.
great.
But no, I've been a clinician for a number of years. It's always been acute care, critical care, and swallowing, except for a late midlife crisis when I did some pediatrics. I wanted to learn more about birth
Yeah.
to adult. I mean, I knew about adult to geriatrics, but I wanted to learn about swallowing in babies. So
Okay.
Little
So
kickstart.
there you go. And who else do we have? This is
I'm Deb Suiter. I am currently at the University of Kentucky, where I'm the director of the Voice and Swallow Clinic. So right now I am doing clinic 5 days a week and teaching dysphagia. I've taught dysphagia to graduate students for over 20 years. And then I do research as well. Probably best known for developing Yale Swallow Protocol with Steve Leader, which is a protocol to assess for dysphagia risk and aspiration risk for people with dysphagia. And then I have been in various positions throughout the years with ASHA. That's actually how I met Laurie and most of the people on that are here in the room. Laurie and I met through SIG 13 years ago, where we were trying to break into working with ASHA and trying to figure out how we could get more involved, and then kind of worked my way up through becoming B6C chair, so chair over all of the special interest groups, and then got involved with CFCC and then became chair of CFCC. And so that's kind of where I am right
Yeah.
now.
Deb and I served as, she was editor and I was a CE administrator for SIG 13 back when it was all paper.
And that's how Julie and I met.
Yeah,
too,
yeah.
just through being,
all right. Now, who are you?
So I'm Julie Blair. I'm at the Medical University in Charleston, South Carolina. It was my first job, my last job.
You work with Yanina.
I do.
I love her.
Yanina.
She's great.
She is amazing. She's got to be one of the nicest people on this.
Oh, she's a jerk.
planet.
Don't,
Except
don't
for-
lie. Don't- She's very
No,
nice.
She's actually way nicer than me. But no,
Yanina Wimskota.
I still can't say her last name.
Oh, she's awesome.
But
She's
she's
super
great.
great.
But yeah, I was at MUSC. Laurie was there with me for a while.
That's how I know Julie.
Yeah, she came to my wedding, and then she left us. But she was my introduction into ASHA. So when she stopped being the CEA, she asked if do you want to do this role?
I forgot about that.
And so I got pulled in at right before they transitioned away from the paper, which is a pretty sweet time
Yeah.
to go into that role. And then I applied for SIG 13 to be on the board and got to work with Deb, where it was the first time I joined Facebook so that she
Oh.
could poke me.
Oh, look at that.
Oh, man, the pokes. I forgot about the pokes. Oh my gosh.
Yeah, so that was my first Facebook experience. I've had just a lot of really awesome opportunities because of the people that I've worked with or been around. Bonnie Martin Harris was at MUSC for a number of years, and so through her, I got to be part of some research and got to do some things at the VA.
So you work with Marty too.
I worked with Marty
Yeah.
Brodsky,
Mhm.
and it was so funny. He would answer the call. It's Marty Brodsky.
I'm gonna call him when he does that. You better look out.
Brodsky kind of gets blurred together to Smarty Brodsky.
Smarty Brodsky. I like it. I like it. I'm
Terrible.
like that.
That's very funny.
Marty, if you're listening, you better watch out.
Marty, so I've been there. I teach the head and neck cancer course there. I work predominantly with head and neck cancer, voice and swallowing, all grown-ups. Occasionally I'll do like a scope on a small person, but that is only to be a helper to a colleague. Otherwise, all big people.
Okay.
Big people.
Cool. All right. Who are you?
So I'm Barbara Messing, and what a journey it's been as a speech pathologist. I never would have anticipated all the little changes and life events and recreation in my career. But I started at shock trauma, as Laurie had mentioned, and that's when I really fell in love with dysphagia, because we would do dysphagia rounds with Dr. Bosma and the team and look at the video studies and, video fluoroscopy studies. And it was just so intriguing. And so that was many years ago. I worked with TBI patients. Then I found the world of head and neck cancer in my next position, and also fell in love with stroboscopy and voice disorders. So laryngeal, those with the larynx and those without the larynx, and airway issues. So it's just been a really wonderful journey. Along the way, I got my PhD through the University of Queensland with Liz Ward and Kathy Lazarus as my advisors. And what an experience that was. And so I learned about research, how to do research, and that's another love of mine. And so I really feel I've just had a great career, and I've been very fortunate. I've met these wonderful women, and we've journeyed through all of it, a lot of it. And here we go, Joe Puntil.
All right, here's Joe.
So
Lay it down.
I'm always the caboose.
Sorry?
Yeah.
No, Julie's the caboose.
No, I'm the caboose. I'm the caboose. So I have worked in critical care my whole life. Vents and trachs kind of are my love, or high flow or delirium and all that kind of stuff. And I'm trying to think of when I met all these wonderful women throughout the career. I did do a lot of stints in ASHA with SIG 13 when it was a SIG 13, and I think I was just
Division 13, yeah.
Division 13 when it was looking either writing something for Division 13 or reviewing something for Division 13. Way back when, I absolutely hated swallowing. Like, I went to school in Illinois and Jerry Logeman trained me. And when I moved to California, the last thing I wanted to do was swallowing. But I worked in this 1,000-bed trauma center. I was low man on the totem pole. I was 15 speech pathologist. And they basically said to me, if you want a job, you're going to have to start a swallowing program. And I was like, I don't like swallowing. I hate swallowing. That's not, I liked head and neck cancer. I liked cleft palate. I liked all these things. And I thought, well, I have to have a job because clearly I needed to pay bills. And so my father always taught me to hang around with people who were a lot smarter than you. And I did. And
you're pretty smart yourself.
Well, thank you. Thanks. But I developed a team of physicians and nurses and respiratory therapists and thought, I know about swallowing, but I don't know about all of the things that happen with swallowing. I don't really know about the pulmonary system or the gut system. And so I proctored classes at UCI and it was wonderful to go to med school and not have to take a test. Like, I could go to med school and go to any class, and all these physicians that I worked with were teaching classes like, come learn about the pulmonary system. So I sat and took their classes, and I didn't have to take a test, which is wonderful. So I learned a lot about things that I never thought I'd learn about, and now I love swallowing. And I've met these women through years of our case studies, and we're also lifelong friends, which I know may not be important to some people. It's important to us.
Yes.
So yeah, I've done ASHA stuff, I've done state stuff, I've seen so many different clinicians do such wonderful things in our field. And I like the things that are coming up. These people coming up in their 20s and 30s are coming up with some fantastic research. And I just want to pass that baton to people about the love of the field. and the love of mentorship versus,
Mhm.
and just exploring and expanding. It's pretty much where I'm at.
Okay.
Yeah,
Right.
I think
Yeah.
we've all mentored and gotten the value for that.
Yeah.
to be
I mean,
able to
I
pass it
love
along.
empowering
Yeah.
younger clinicians and
Me
like,
too.
getting them more involved with swallowing, getting them involved with ASHA, what have you.
Well, and I think about all the opportunities I was given,
Mhm.
and if I had not had the people that were part of my career, part of my work family, I would not have been able to do any of the things that I've done. And I just had 30 years at MUSC. And they had,
Congratulations.
thank you. And the younger clinicians had a little thing for me, and they were asking, what advice would you give new clinicians? And it was, to me, it's say yes to the opportunity,
yeah.
say yes to
Be open.
to be open to participate. You want to be part of this research? Yes. Do you
Yes.
want to present? Yes.
Yes.
Do you want to do a study? Yes.
Yes.
It
That's
just
true.
Do you want to see a patient at 6 o'clock that needs your help?
Yeah.
Yes.
I'll do it.
Do it.
Right.
Because it makes an impression, and people remember, and you'll get asked again.
Right. And doors open.
Yeah.
Right.
Doors
Right.
start to
Doors,
open.
doors open.
Yeah. So
I would say we've learned, I don't know about you guys, but I feel like we've learned so much over the years. Our field is still continuing.
Yeah.
I think we have a lot more to learn and about swallowing and it's just ever evolving. But I think that growth is really important. And I think we get that by connecting with each other, by reviewing studies and discussing. That's why we got together every year and did that. We
Right.
took our unusual cases and presented them,
Mhm.
things where, like your nuts patient who
Oh, the
Oh,
nut
my
case.
God, nut
Talk about that. Spent an hour on the
yeah,
nut case.
or my patient who swallowed the denture. I mean, we can
I
learn
had
from
one
each
of
other,
those,
right?
too.
Yeah,
It's
it's
like we need a
amazing,
club.
but we learn from each other, right?
Right.
It's important.
That's good.
and learning from our maybe not so successful interactions. So, wow, I really thought that this patient had this going on, but boy, was I wrong. And what did you learn from it? Because I think everybody needs to realize even the experts aren't necessarily always the expert. They're still learning. They're still figuring
Right.
things
So I
out.
think admitting that we're not perfect
Yes.
shows
Yeah.
our vulnerability. I can't say the word to people. But yeah, I think admitting that we don't know, we don't have all the answers. I will text any of you all in this room.
Yeah. We send
and
pictures.
say,
We send
yeah, what is
videos. We send videos like, what is this?
Right. Yeah. I mean, it's 30 years into a career, and I still don't think I'm perfect, and I know I'm not.
Well, and on that note, I know at least four of you. Are every one of you an ASHA fellow? Everyone.
Yes.
Yes.
Every single one.
No,
What? No.
She
Me
will
and
next
you.
year.
You will be next
We
year.
hope
You're
we're
gonna-
gonna nominate
We're
Julie.
gonna have a good time. We're gonna hang out and let these losers do their own thing. You know.
Yeah, Lori.
Me and you.
Next year, Julie.
Well, okay, 4 out of 6 of the people here are ASHA fellows, and I don't count. So 4 out of 5 people here are ASHA fellows. There we go. And so there's
But I
odds.
lost my pin. I'm sorry.
You lost your
I lost mine too.
Does that mean that you lost your fellows?
I'm still
And I'm wearing my pin proudly tonight.
Lori is
But
very
the point being is that you've been around, you've been practicing for a long time, you've been honored by your association, and there's not perfection still there, but you're willing
Right.
to admit and reach out for help. And so I think a lot of us, I can't say it anymore because I'm not, the young whippersnappers, right? Come in and we're like, we got to know it, we got to do it, versus coming into it, learning from our mistakes and being willing to make ourselves vulnerable and ask questions. We're not always trained that way. We're kind of sometimes chastised for imperfection, which is a totally backwards
Yes.
way of living that promotes a facade and being pretentious and does not do what's best for patients. But anyway, I could
I've
go.
always said to my students that the minute you think you know everything is the
Yeah.
minute you need to get out of the field.
Yeah.
We need to always question everything that we do. I still do it every single time I do a modified.
Yeah.
Yeah.
Barium swallow study. I question everything I do, and if you get to the point where you're comfortable, you don't hurt people.
Right. Right.
You look at the progression of science, and so we're at a pretty good point because 2024, like there's been some very logarithmic exponential growth, and we know a lot. But like if you go back 200 years, they probably thought they knew their stuff okay, and we're probably pretty confident in it. And so, like, how do we know we're not there? Like, how do we know we're not there right now? And in 100 years, they're going to discover so much more, and we're going to be like, oh yeah, that's pretty dumb. overall too. So you've got to have an open mind to it and be humble about it. But about this thing that you all got together and did for 17, was it
I
17
think
years?
15 years.
15 years, a long time.
Yeah.
Swallowing cinema. What is the swallowing cinema?
Well, it started out with Nancy Swigert, who thought that we should have, say, at least one lecture every single ASHA with board certified specialists in swallowing and swallowing disorders to give case studies to just show that you have an elevation of credentials and that you show your vulnerability, that you're going to show this case study that's kind of unusual and how you reached out to a team to figure out what to do with that. And that's where it started. And it evolved into something that we just do every single year now. And more people have gotten involved in it. We've been involved in it for I don't know how many years.
Yeah, I was the newest addition
I'm the-
to.
You're looking at Deb. She's just.
I'm the oldest. I'm the one Nancy had me start it with Donna Edwards, and I can't remember the other person. I feel bad. I don't remember who the other person was, but she was a board certified specialist. And then it went on from there. And it was always something about bedside swallows or clinical swallows of L's and then instrumentals and
Right.
what you do with patients from birth to
It was almost like before fees was really
Yeah.
so much in practice,
And then
right?
we
It
brought
was a lot
these into it.
Right,
as we
right.
offered, yeah.
And then you brought in high resolution manometry.
Yeah.
Yeah, me too, yeah.
So, but it's basically, these are case scenarios,
Right.
case studies that you
We
go
thought
through.
of the most of cases that were challenging to us
Okay.
from the year. We were really thoughtful of the cases that we
Right.
selected because we wanted them to be a learning experience for
Right.
the attendees. And we had
I've done things where like I've been wrong, I was just like, and the patient thought he was aspirating all the time. He wouldn't eat because he was coughing constantly. And it was actually just his tumor pressing. And when it went through like when we finally did a modified, I didn't do a modified right away. I mean, it's kind of sad. He could have kept eating, but they like pegged. Never mind. It's just, but I don't know if they pegged him or not. It's been so long, but it was just like as the bolus went through like kind of the aortic arch area, he had a mediastinal tumor and it was kind of pressing on the nerves and stuff. And so he coughed when it went through there. Everyone was fine. But he was like, I can't eat. I haven't eaten in a week. And they found that
Great
tumor.
justification for an AP view involved.
Yes.
True that.
that's the other part.
Which we did, but we could see that,
That's the other part of it that we'd like to bring forward is how do you examine, what do you do for your instrumental? It's not just a lateral view and it's lips to, I'm going to say it, lips to LES.
Yeah.
And you have to look at the whole system because there's an interrelationship between what's happening between the oral pharyngeal and esophageal. Let me say the word phase because they are phases, but they're not really phases. It's just lips to LES.
Right.
And you have to look at the whole system.
Right. Because if the drain's not working, you're going to have residue in the pharynx, right?
You're going to have pressure
Yeah.
differentials.
You're going to back up. Your system's going to back up.
It's all one tube, is what I say almost daily. It's all one tube.
All one tube, yeah.
Part of that
With some
Yeah.
chambers and valves.
Exactly.
Yeah.
Right.
Yeah.
There's pressure differentials, and those pressures are going to affect the pressures in the esophagus are going to affect the pharynx. I'd like to pick sometimes cases where we allow people to aspirate, and then is like what Jim Coyle and I talked about with one of your podcasts was you can't always eliminate aspiration. So can we just do what's best for the patient and then work on pulmonary clearance tasks, work on oral stuff, keeping your mouth clean, keeping people mobile and letting them aspirate and living a life that they want to live instead of what we think a patient should do.
Well, we do that with so many of our patients
Right.
that are post-radiation patients.
We do.
We do with head and neck.
ALS.
Yeah, ALS. I mean, absolutely.
Thank you. But
Yeah.
for some
What's important to the
reason
patient?
in the acute neuro world, if they penetrate on a modified
Right,
variance
exactly.
model, people freak out. And
Right.
it's like, whoa.
Right.
Let's
But we keep coming back, and I repeatedly come back to that Langmore paper in 1998.
that's a
How
seminal
many years? I mean,
It's
that's
25. More than 25.
It was pointed out that it's just old.
I count the years.
you need to keep coming back to that paper
Right.
and why has that not caught on with so many people? But that's the paper I go back to repeatedly with my
Is it the
patients.
people or the physicians? Because we are facing an aging population of chronic aspirators,
Mhm.
and they keep coming into the hospitals, and there's no pathway for them. And the doctor's like, oh, if you're aspirating, well, you should be DNR and on hospice. I'm like, what?
But
but-
nothing
so
saying
the
that being
doctors-
on a PEG tube is going to reduce.
Well,
their
no,
incidence of
that too,
aspiration.
yeah.
So that's how things are. And but how do we fix it? What are the barriers to get there?
It's education.
Well,
of
and also giving the
physicians
patient
too.
what are the patient's goals?
Yeah.
Right.
Okay.
We have to
You
be
know.
the advocate for the patient, and certainly we have to give them the most, whatever's going to be the safest recommendation. But what do they want? As you were saying,
Right.
is really important, and bring that into this discussion with the physician.
Yeah.
Well,
I've had lots of patients lately where the families are like, we're not going to do thickened liquids.
Yeah.
We're not going to do a feeding tube. And I said, okay, then we're going to do what we can do. And so water, brush your teeth, let some water,
Yeah.
aspirate. Let's do some EMST. Let's do pulmonary clearance tests. Let's get them motivated. Our OTs and PTs, when they know someone's an aspirator, they get them up and move them faster. The
Yeah.
OTs get them to
That's-
brush their teeth and feed them.
That's
That's
super-
their goal, is up in a chair for meals, brush your own teeth, feed yourself.
If you're looking at it comprehensively, you're looking at why we care about aspiration. Okay, pneumonia, asphyxiation,
Mhm.
whatever pulmonary sequelae, but then you're also considering all the other variables that can relate to those things and trying to control those. Freaking makes sense. It's multidisciplinary work. And so like
You're making
it's,
sense.
I also want to do, I also
statement.
I also want to do a plug for therapy, because in the acute care setting, right, we
Oh,
can't
yeah.
just diagnose, we can't just assess
Diagnose an
give a
adios.
diet. So
That's
I-
diagnosed and adios. I say it all the time.
I think it's so important for us to use the skills that we've learned for therapeutic interventions and implement them, and also use our instrumental examinations, the fees, to do those strategies that we're implementing really going to help the patient. And I think that will guide how we can optimally help the patients.
I
But
think
the
you're
frustration that I have though with therapy is if I bring somebody back, first we still don't have guidelines for how many repetitions does somebody need to do these exercises, for how long. So you bring them back
you missed that.
and there's no real,
43?
there's no improvement. And so then it's like, did I not tell you to do the right exercise? Are you not doing it correctly? Did you not do it long enough? Did you not do as many repetitions? That's the frustration for me.
There's a magic number though.
But
I mean,
there's
you
have
have
to
to
individualize.
Yeah.
There's
They're
not
guiding
a-
principles, but then there's variability within
Right.
them.
Right.
Yeah, we have to
But-
modify.
But when somebody comes back and doesn't improve, you've got to, that's the
Yeah.
thing that as I've gotten further into my career, it's not like, the exercise didn't work. It's like, did I do something? Is there something that I didn't suggest for you that would benefit you?
Well, sometimes we get to that point where there is not,
Right.
we've done everything we
Right.
can, but I think we should do our best to use the skills that we have and the interventions, whatever they might be, and then guide it, based on that patient.
Yeah, exactly.
Do something, try.
So there are a lot of different things here. There have been
Yeah.
plenty of things that we could tangent and talk about for a very long time.
Yeah.
So, like a moment ago, the idea was mentioned doing what is as safe as possible.
Right.
Uh-huh.
However, I bet if I went back and said, "What do you mean by that?" that it would be more to it.
What
Yeah,
is
sure.
what is safe?
Well, what is safe?
Well,
It
it's
is
the
life meant to be
patient.
lived as safely as possible.
Yeah.
I drive a car every day. That's not very safe.
Do you wear your seatbelt?
I do. Yes. Yeah. Yeah. Absolutely.
Rely on the tools that we have,
Yeah.
right?
Yeah.
To make our best clinical judgment,
Yeah.
to be able to render a clinical decision to the patient, and then we work with the patient based on their goals. We implement our
Yes, yeah.
strategies, our therapeutic interventions. We do the best that we can. There's no magic wand. I many times wish I had a magic wand for our head and neck cancer patients, and that doesn't exist. So
No.
sometimes we have to understand that we've
Well, you
taken
live
this.
with aspiration and you wait
That-
and see.
Right.
Yeah.
And
Right.
And that's what I'm going with is it's more than safety. It's
Quality.
It's
multifaceted.
back to the
quality of life.
article.
Right.
Exactly. Well, because if we're
Quality
just safety,
Yes,
they
that's right.
aspirate, we stop. Okay, that's not safe. They aspirate, we stop. Then we or we
And they
do
atrophy and
honeythick
then they get-
liquids. We
Right.
transfer it to
There you
the
go.
kidneys, or we.
But
do
if they haven't had multiple hospitalizations for pneumonia, just
Who cares?
talk to them about
They're-
this could happen. I don't
I
know,
ask
because
them,
we don't know how
Yeah.
much somebody can
I
aspirate to get pneumonia.
Regular
Yeah.
basis.
And so keep going.
Yeah.
And here are the best things I know to help you mitigate that.
I think most of the
Yeah.
time the patients are going to make their own decisions based on information that they know that
Give her
their own goals,
their
and
SLP.
they're going to listen to it
Yeah.
too. I mean, they need to draw on that.
But you have to be careful because a lot of times people are going to put their own biases in their
I was
recommendations.
just going to say that.
And you've got, especially older populations, I think they are less likely to question whatever somebody tells them they need to do
That's true.
from a healthcare
Yeah.
standpoint. One of the best things that happened in our facility is we got palliative care more involved in the care of patients to have goals of care discussions with our patients, because our surgeons are wonderful, but they want to fix the patient, and sometimes it's not
Yeah.
fixable, or the fix could actually come to sometimes be worse than what they've got, and having some discussions with patients to where they really, really understand what are your choices and what do those choices
Yeah.
mean.
That's
Right.
right. That's right. That's part of our ethics. That's part of the basis of what we are supposed to do as speech and language pathologists is first, do no harm.
Yeah.
Second, educate the patient. Well, maybe not in that order, but educate the patient.
Uh-huh.
Educate them on and balance between function and whatever.
Quality and
yeah.
quantity.
You have to balance that.
I mean, ultimately, they're in control. And so we're helping them. We're providing the information based upon our knowledge and skill set to be able to make the best decision as possible.
I
They
think
couldn't
that's
make without us.
exactly it.
Yeah.
We are there to provide education, but at the end of the day, what they decide to do
Right.
is up to them.
100%.
And what happens when we get into the mindset that's like, okay, I'm going to protect myself because I don't want to get sued. And so I'm going to document. I told this patient, you need to be on mildly thick liquids. And they said, I'm not going to do it. And I said, but if you don't do it, you might get pneumonia, you might die. And they said, oh, I'm still not going to do it. Versus they said they're not going to do it. So like, okay, well, what else could we do? Like you realize, there is a risk involved. And I'm not, without getting into the nuance of sick and liquids, I'm not a huge fan, but just whatever it is that we're trying to do with our recommendation. And if they don't like that, maybe finding another way that they're okay with.
Right.
I think it's understanding, are you protecting you or are you protecting the patient?
There you go. They're
Yeah.
in control.
Right.
Yeah.
There was actually there was a good presentation today, and I'm sorry, I hate to like only remember one of the presenters, which was Nicole Rogas Puglia, but it was on with dementia, and it was providing the families with choices of like, okay, do you want to drink mildly thickened liquids?
Mhm.
Do you want to do thin liquids and start doing better oral care?
Mhm.
And it was like
Love that.
providing the
Love it.
patients with choices, and they're like,
Yes.
do you want to
I love
do
that.
do you want to do EMST, or do you want to do like an effortful swallow and like some exercises and stuff like that? And they chose like EMST, and I'm like, that I was like, wow,
Nicole's
boom.
fabulous.
Yeah, it was, but it was out of
Yeah.
her lab at
Yeah.
University of Wisconsin,
love
and I was just like, boom.
Boom.
I've been practicing forever. I'm like, this is excellent because,
Well, that's
I'm dealing with, now that I've moved out of the Texas Medical Center, I'm in a community hospital, much more of an advocate for my patients because we don't have the resources. And just like for being able to provide them, that's an awesome, like give them an option.
It just shows
Give them like
how
two
much
choices.
we can
See something, they're more likely to actually
Right, for
follow
quality
through.
of life. And that's what they had, like high adherence. And, and I don't like they're not adhering to my recommendations. It's their choice. I don't, I'm not big on that word, but
It's better than compliance.
It's better. I was gonna
oh no, maybe adherence is okay. It's the non-compliant that drives me bonkers.
They're a prisoner.
Yeah, like he's non-compliant. I'm like, no, he doesn't want to do it. Thick liquids suck.
Can we take this a step further?
Yeah.
What you're saying is take it a step further for those that work in acute care that have to pass a patient on. So I had a patient who's
Yeah.
a Parkinson patient. I just presented this on a Tim's University, and he was Parkinson's, known aspirator, was in our hospital for COVID, aspirator, with thin liquids, pooled with pureed, esophageal issues, went to a care center. The therapist at the care center insisted he do thickened liquids. Of course, he comes in the hospital. He's an indwelling catheter because he's got an issue that doesn't have anything to do with speech pathology. So he comes in the hospital with altered mental status, and the very first thing very delayed response, altered all that. And he said, I don't want any thickened liquids. So what we did was we did exactly what they wanted, like you were just saying. His preferences, wife said no thickened liquids. We knew he was a known aspirator. And then we passed it on to the patient that was going to the care center, again, different care center, to the speech pathologist. I called the speech therapist and I said, hey, you're going to get a patient of mine this is what's going on. And they did the same thing that we did. So we followed up
Awesome.
with respiratory stuff,
Nice.
keeping his mouth clean,
Yeah.
physical therapy involved. We're going to let him aspirate. And the wife was ecstatic because I said, let me call the speech therapist
Yeah.
instead of you saying the same thing over again.
Right.
Continuing.
We work with great therapists. And then he came back to the hospital a month later because he was, quote, better, right? Now he's going to do his modified again. We're going to repeat it, and this modified is going to be better. Guess what? It wasn't that much better. So he's still an aspirator. I still showed everything to the wife and the patient, brought him, and he hasn't come back with a pneumonia. So here's a guy who's Parkinson's.
Yeah.
Everybody would freak out
So
about
the
it.
question is, who cares?
Right, who cares?
Right.
So,
Make
Yeah.
a choice.
Exactly.
Who cares?
he came back to the hospital like 2 weeks later, altered mental status, sepsis,
Oh,
because he had an indwelling catheter. And
I was ready to UTI.
ICU docs are like, okay, he's an aspirator. What are we going to do? I said, we're going to get him up in a chair. We're going to do, we're not changing anything. And they were good with that because we kept the patient preferences
Right.
Yeah.
and we protected the patient as much as we could.
Yeah.
And followed through with what they wanted, what the skilled nursing speech pathologist wanted, all of that. Like we all
100%.
put the
Very
patient
important.
first.
Yeah.
Instead of, oh my gosh, he's aspirating, you got to have thickened liquids. No.
Well,
My wife was sneaking him coffee every morning. I'm like,
Yeah.
if she's sneaking him coffee every
There's
morning,
quality of life.
there's quality of
Yeah.
life.
Yeah.
100% agree with that.
I had a thought. It left me.
Welcome to my
I was just saying,
No, well,
I just
Oh,
think
yeah.
we need to pass on information to people, not just live in our silos, but like if I'm going to pass a patient to you, I'm going to call you and
Yeah.
say, hey,
Right.
I mean, I did that the other day. I said, you're going to get this 92-year-old train wreck. She's a doll. Her son doesn't get it, but she's a doll. And this is what we were doing. And those guys call us and say, hey, you're going to get a patient from us who's, had another stroke. Something's going on. Make sure
Yeah.
you follow them. That communication to the person passing back and forth, I think, is vital.
it
Yeah.
really.
continuity of care is really
That's a huge issue.
We can't forget when we're discharging the patient that
They're
we're going
somewhere.
to an abyss. We have to think about where they're going,
Yeah.
how those recommendations are going to help them carry on.
I think
Yeah.
the hard thing in acute care is like they're gone the next morning. I didn't know
Yeah.
they were going. I mean, like I can
Mhm.
monitor case management, but I don't know that they've gone.
Well, but what if you have a good relationship with the people in the community and they know they can call you? So you might
Yeah.
not get to call them preemptively, but they know they can reach
I
out
get
to
I
you.
have people call me, and I know there's probably HIPAA issues, but
I also
it's not as long as you're involved in the care. Okay, I was going to say HIPAA schmippa, but
Hey, we're not going to identify who that was that said that.
I asked the patient and I asked the wife.
Solidarity.
yeah,
Okay, that like this 92-year-old I saw last week. I said, is it okay if I contact the people in the
yeah.
desert
I talked to them.
and talk to them? And I documented it. Patient and son.
Legally,
Yeah.
you are allowed.
You're allowed to do
communicate
that.
with
Yes,
them.
Because I will
It's-
tell anybody who
it's nice
calls
of you
me,
to ask.
whatever.
But
Yeah.
I'd like to ask, is it okay
nice
if I
of you to
call them?
ask.
And you want me to call them? And I document that the patient and the son said it's okay, and I just document it just so that like nobody
Yeah.
get Freaky Friday on.
But it is called continuity of care.
Yes.
It's something that we should be doing. It's not, we don't have, it's something that's really important to help that patient.
And the
to
people in the
transition
community,
to home.
they appreciate it. They call me all the time and say, hey, you're getting someone back. And then once you get that ball rolling, it doesn't stop. It just keeps, it's a wonderful relationship with the people in the community.
Yeah.
Yeah, I want to go back to the mentorship thing because for young clinicians, if there are like young clinicians listening to this, find a mentor, reach out.
Yeah.
I did that early. I reached out to Barbara Sunnies and would call her like all the time. So find someone to help you to, bounce
Problem
things
solve.
off of,
Yeah.
whoever that might be, whoever you feel that you respect clinically.
Yeah, that's
And
important.
make those connections because there's a lot of questions unanswered that you may find that having a mentor is going to really help you through your career.
And I think all of us here sitting here did that,
Yeah.
right? I mean,
Yeah.
I did that
I
with
was
Steve
blessed,
Leader. I mean, we've all had people
A
that,
mentor in our life,
that
or
we had
multiple
mentors
mentors.
with.
Besides each other.
Right. Besides each other.
Yeah,
And
now they're-
I think right now we have each other, but also we are I know we're all very passionate about mentoring the next generation
Yeah, yeah.
Absolutely.
of clinicians.
It's like a good continuity of care thing.
Absolutely.
And don't
Yeah.
forget about
Knowledge,
BCSS.
passing
Yes.
knowledge on.
Yeah,
Yeah.
passing it on and
No,
empowering
that's
people.
good. Well, we probably wrap this up. I don't think there's really necessarily a core theme to this episode other than the fact Daggone. I had something there. I had something there. It was gonna come out, and I planned to
It's gonna be
edit this
very
episode.
profound.
I mean, it's gonna be so
Wait
profound.
till you're
Just wait. Your
63.
socks are-
Wait till you're 63. It just like disappears.
Tell everyone you say it.
I look good for 63. I never tell them.
But so anyway, but back
You're older
back
than
to
me. Stop it.
just to summarize a couple of things that we've gone through. The importance of communication, I
Yes.
think, key. You know, the importance of vulnerability, not faking it till you make it. Which, man, I don't know how many episodes I've said that on. People are going to say,
Yeah.
"If you said that one more time, I'm going to shut this thing off." But you know,
It's true.
being vulnerable about what you know, and that goes with the mentorship too. Finding a mentor who will accept you for that and not expect perfection, because certainly they're not. And so you know you have a pretentious, dishonest individual if you have someone who's doing that. But being open and willing to communicate with each other as speech pathologists when you need help, but also when you're handing off care too, so people feel like they can reach out to you and you can reach out to them. Man, there's a lot more with
Listen
this.
to your patient.
Yeah,
Yeah, listen to your patient.
Read a room.
read a room.
Read the room.
Read the room. If you're in acute care or outpatient and someone comes in with that patient, read the room. Look at the person that's with that patient. Read the room with that patient. I think we don't get those soft skills
Yeah.
in school, and we because we've worked for many years can read a room really fast.
Mhm.
But those are skills that are difficult to learn. How much information do you really give? Like we're giving information about a modified. And I said, this is easy peasy. This isn't rocket science. I'm not a rocket scientist. Let me show you your modified barium swallow. And I don't give term unless they're in medicine. Do I give
Yeah.
terms?
Right.
But I'll say, I have a system that you know the TIM system, so you can say you can draw on there. And I
Like,
say,
here's your flapper.
here's and it's like, you don't want this going here.
It's like a laundry chute.
Since
And
things
the more you understand why you're doing what you're doing, the more you're going to be able to help not do the things that you're going to be able to follow these compensatory strategies easier. But read a room. Like there's times I'll be talking, and you can tell the patient
They're
and the
glazed.
spouse are just
Yeah.
I would
Well,
think
not processing anything else
I
at
think
this
it's
point.
important not to take those things for granted too, because they come so easy to you after years and years of experience, but it took you a while to get there. And so not forgetting to break those things down and to explicitly provide instruction to students on those things too. So not just the physiology, not just what you see and why it matters, but the importance of communication. Because if you're handing off somebody from acute care to a long-term care facility or whatever,
Home, or even discharged at home.
you could have the best note. They might not have the time to read it, but they have the time to pick up the phone and you can explain something to them in 2 minutes and they can ask questions and whatnot. It goes a long way. And so just not forgetting about those things. So I guess, I don't know, one thing that I'm pulling out of this is to look beyond the concrete and the immediate, the physiology, the what you see, but really to emphasize like reading the room and the communication, why it matters. It's just a lot of different things.
One little point I would like to make
Yeah.
is don't forget about the caregiver in the room.
Right.
Because they are so critical to the rehabilitation of that patient. They're living with it. And oftentimes they are the ones that's forgotten in the room, but they have to go and cook the meals and help
Yeah.
the patient. So
Well, it's just
That's what-
understanding what's important to the patient, what's important to the caregiver, absolutely. But what do they ultimately care about? I think is the thing that as I get closer and closer in age to many of my patients, that's the thing. It's like what am I doing to my patient when I'm making these recommendations?
Yeah.
It's real. You can relate to them more, and so you empathize with them more. And you're like, what would I want if I were in
Right,
their
exactly.
position? Yeah.
Yeah.
No, it makes a lot of sense. And just a reminder, this is a very laid back episode. This is talking. There's not something directly that we're looking at, other than a bunch of people who are very comfortable speaking with each other, who are bound by relationship of doing not just swallowing cinema, but working together in a number of different ways in the past. And I think one of the reasons you gel is because you've got a pretty like laid back, similar mindset on a lot of these things, and that's very refreshing to hear from a lot of your perspectives with that. Is there anything at all that you want to leave with? A lot of really good things to draw out of that, and looks like you got to take off. Don't need a ceremony, huh?
Yeah.
No, that's
It's ready to get.
Read the room.
I'm ready to go.
read the room.
I mean, the relationships that we've formed over the years, I mean, we've all been friends for, at this point,
Long
over
time.
20 years,
Yeah,
at
no,
least.
no.
I mean, but we love each other because we all, at the end of the day, care deeply about the people that we serve and care deeply about the impact that we have on other people and just
Well said, Dr. Suiter.
Yes,
These professional relationships are what
important. They're really
Yeah.
important to my life. Yeah. Yeah.
But these are the most important relationships that outside of my obviously intermediate family that I
Yeah.
Yeah.
Yeah. My husband just thinks I shove applesauce in people's faces all day. So I didn't get
I would say the other thing, the last thing is that when I started my career, I thought I needed to read everything, learn everything, and I felt overwhelmed. And somebody told me that's what you do every day is you practice, practice, practice. And
Oh,
that's
wow.
what that's
That's
what
awesome.
it's all
Yeah,
about.
yeah.
It's just your practice. And it
Right.
gets better, but you learn as you go.
Very cool. Well, thank you all. Really appreciate it.
Thank
Great
you.
to meet
Thanks,
and
Kim.
re-meet and hang out. And
Yeah.
look forward to chatting again.
Thank you.
Thank
Thank
you.
you.
That's another episode of Swallow the Gap. Special thank you to our guests, Julie Blair, Laurie Sterling, Dr. Deb Suiter, Dr. Barbara Messing, and Joe Puntil. And I'm excited to announce a special 2-hour webinar coming in late February involving most of these ladies, diving into some fascinating modified barium swallow studies. And this course continues the 15 or so year legacy of swallowing cinema. For more information, keep tuning in, or sign up for the mailing list at swallowthegap.com, or follow me on Instagram at swallowpatho. That is at swallow, P-A-T-H-O. Gap Education's last 2 webinars for ASHA CEUs received stellar ratings at an average of about 4.8 out of 5. And they were a lot of fun, so we hope to see you there. Additionally, visit swallowthegap.com for more information about upcoming live and recorded courses in 2025. Many of them, actually most of them on there, toward the beginning of the year. And last but not least, a special shout out to this episode's sponsor, the Milton J. Dance Endowment, a sponsor dedicated to supporting head and neck cancer patients and individuals with swallowing disorders across all populations. Thank you for listening, and we'll see you next time.